Welcome back to the deep dive. Today we're diving into one of the most clinically sensitive and I think fascinating areas of pharmacology. Chapter 22, Psychotherapeutic Agents. Our goal isn't just to list drugs, it's to give you the ultimate shortcut to understanding the mechanisms, the critical safety alerts, and, most importantly, the vital nursing considerations that keep patients safe.
And this is a really high-stakes deep dive. I mean, we are talking about medications that are targeted at altering fundamental thought processes. They manage these severe behavioral disorders, primarily psychoses like schizophrenia. And the core concept you have to grasp right away is that these agents, they don't offer a cure.
Right.
They're transformative in helping patients function, but we are managing symptoms. The whole theory now is that these disorders stem from an inherent chemical imbalance in the brain.
That sets the stage perfectly. So what's on the menu? We're tackling three crucial categories today. First, the antipsychotics, which are often called neuroleptics. Second, the mood stabilizers for bipolar disorders, lithium, is kind of the star there, but we'll touch on others. And finally, the central nervous system, or CNS, stimulants, ADHD, narcolepsy, that sort of thing. Okay, let's jump straight into antipsychotics. They are essentially defined by their primary job, which is what? Blocking dopamine receptors. And they get that other name, neuroleptics, because that blocking action causes a whole host of neurological adverse effects.
Exactly.
But before we get into the science, let's talk safety first. The source highlights two sets of drug names that could be an absolute disaster if they're confused.
Oh, that's right. I mean, when a patient's life depends on dose precision, name confusion is terrifying. The first pair is the antipsychotic chlorpromazine versus the anti-diabetic drug chlorpromazine.
One for psychosis, one for blood sugar.
A huge potential for error. The second pair is the antipsychotic risperidone, that's Risperdal, and the anti-Parkinson agent ropinirole, or Requip.
You really have to drill those into your memory.
Absolutely.
Okay, now for the mechanism. This is where we see the split between the old and the new approaches. How do the typical and atypical antipsychotics differ?
So the typical antipsychotics, think of the classics like chlorpromazine and haloperidol. They're mostly just dopamine blockers. They essentially slam the brakes on postsynaptic stimulation and powerfully depress the reticular activating system, the RAS.
The brain's filter, basically.
Exactly. They severely reduce incoming stimuli. They also have some secondary anticholinergic and antihistamine effects.
And what pushed researchers toward the atypical agents was the big change there?
Well, the newer atypicals like aripiprazole, clozapine, risperidone, they block both dopamine and serotonin receptors.
Oh, okay.
And adding serotonin blockade is the conceptual leap. Serotonin is so strongly implicated in mood and cognition. So by blocking both, the idea is to treat the positive symptoms like hallucinations, but also the negative symptoms like apathy and withdrawal.
And hopefully reduce some of those awful neurological side effects.
Hopefully, yes, though not eliminate them entirely.
That dual action is the key takeaway then. Now, moving past psychosis, I found some of the secondary uses for these drugs just fascinating.
They are, yeah. The applications are really wide. Chlorpromazine, for example, can treat intractable hiccups.
For ones that just will not stop.
Right, severely persistent ones. It also manages severe nausea and vomiting. Haloperidol is a go-to for rapidly calming acute psychiatric situations.
And what about prochlorperazine?
That's a powerful antiemetic. You'll see it a lot after surgery or chemotherapy.
Okay, let's zoom in on safety. I want to pause on the pharmacokinetics because one detail here has, I think, massive implications for nursing.
You must be talking about the drug storage.
Yes, exactly.
It's critical to understand. These drugs are highly lipid soluble, so they get widely distributed and stored in body tissues. This means they can continue to be released into the bloodstream for up to 6 months.
6 months.
6 months after the patient has stopped taking the medication.
So a patient stops their meds, maybe they feel better, or they're just non-compliant. You still have to track them. Side effects could pop up months down the line.
Precisely. And speaking of safety, we have to talk about the huge black box warning.
Yes.
Antipsychotics are never approved for use in elderly patients with dementia to control behavior.
It's just not what they're for.
Not at all. It causes a significantly increased risk of cardiovascular events and sudden death. It's strictly contraindicated.
Okay, let's get into the side effects that demand that constant monitoring. the extrapyramidal side effects, or EPS.
Right, EPS. These are movement disorders that result directly from that intense dopamine blockade.
That's a whole spectrum.
It is. And you have to know these four. First is dystonia, acute muscle spasms, often twisting the neck or tongue, really distressing.
Yeah.
Then akathisia. This isn't just movement. It's a terrible internal feeling of restlessness. The patient cannot sit still. Third is pseudoparkinsonism, which looks like Parkinson's tremors, a shuffling gait, muscle rigidity.
And the last one is the most feared, right? Tardive dyskinesia, TD.
Correct. TD is the one you really, really don't want to miss because it can be irreversible. It involves involuntary repetitive movements.
Like what?
Lip smacking, rapid eye blinking, tongue darting. On a positive note, we now do have treatments specifically approved for TD symptoms like deutetrabenazine and valbenazine.
That's good news. So what other big risks are there? I see notes on endocrine and cardiovascular issues.
Yes. Due to increased prolactin levels, patients, even male patients, can experience gynecomastia.
Breast enlargement.
Exactly. And on a less alarming but, noteworthy point, the phenothiazines can cause a benign but startling change in urine color to pink or reddish brown.
That is a great patient teaching point to avoid a panic attack.
For sure. And for cardiac and metabolic risks, we have to watch the heart. Drugs like thiordazine and ziprasidone can prolong the QTc interval.
Which puts them at risk for
A fatal arrhythmia, so a baseline and periodic ECG is mandatory. And don't forget, the atypicals carry a serious warning about major weight gain and the risk of developing diabetes mellitus. You have to monitor those blood glucose levels.
Okay, let's wrap this segment with nursing implementation. What are the quick, non-negotiable safety takeaways?
Never crush sustained-release formulations, ever. You risk immediate, dangerous toxicity. After a parenteral dose, keep the patient lying down recumbent for 30 minutes to manage orthostatic hypotension.
And monitor blood work.
Yep. Monitor the patient's CBC for potential bone marrow suppression.
All right, shifting gears to bipolar disorder. This is the condition defined by swings between that debilitating depression and periods of mania, that extreme hyperexcitability. We use atypical antipsychotics now, like clozapine, or anti-epileptics like lamotrigine, but lithium. Lithium is still the historical gold standard.
Lithium is fascinating because it's just a simple salt. Its mechanism isn't a simple receptor block, it's a membrane stabilizer. It alters sodium transport in nerve and muscle cells. It inhibits the release of certain neurotransmitters. Basically, it helps stabilize and modulate those hyperactive manic neurons.
Now, we have to emphasize the danger here. Lithium is a toxic salt, and its therapeutic range is, well, it's notoriously narrow.
It is a razor's edge. The effective therapeutic range is 1.6 to 1.2 mL/qL.
Wow.
Staying within that tiny band is the single most important monitoring responsibility.
So let's talk about what happens when patients start creeping above 1.2.
The progression is rapid. Below 1.5, you'll see initial lethargy, a fine hand tremor. But once you hit 1.5 to 2, the tremor intensifies, you see GI distress, and cardiac changes start appearing on the ECG. Anything above 2.5 mL/qL is a full-blown medical emergency. We're talking ataxia, seizures, severe hypotension, multi-organ toxicity, and a very significant risk of death.
This brings us to the biggest teaching point for patients: the vital connection between lithium, sodium, and hydration. Why does dehydration or a low-salt diet immediately push lithium levels into the toxic range?
You should think of lithium as riding on the same bus as sodium. When the body gets depleted of sodium from sweating, diarrhea, diuretics, the kidneys try to conserve every bit of salt they can find.
Okay.
And because lithium is handled so similarly to sodium, the kidneys reabsorb more lithium too.
So it concentrates the lithium.
Very, very quickly. It leads to toxicity. So patients must maintain consistent, adequate hydration and salt intake. They can't just suddenly go on a low-sodium diet without talking to their provider.
So what are the absolute contraindications then?
Significant renal or cardiac disease where fluid balance is already compromised, and of course, sodium depletion, dehydration, or using diuretics. Clinically, we also have to note a major drug interaction. Combining lithium and haloperidol can cause something called encephalopathic syndrome. It can lead to irreversible brain damage.
That's terrifying.
It is. That combination has to be strictly monitored. Also, a weird one. The herbal remedy psyllium can block lithium absorption, making it totally ineffective.
Excellent. Okay, for the nursing care summary. Give it with food to avoid GI upset, and remember to decrease the dose after an acute manic phase resolves.
Right, because tolerance to the drug actually decreases once the mania is controlled, And of course, because of the risk of congenital abnormalities, pregnancy avoidance is essential patient teaching.
Our final category, CNS stimulants used for ADHD and narcolepsy. So these are stimulants like methylphenidate or dextroamphetamine. Yet they have this paradoxical effect. They actually calm hyperkinetic children. How do we explain that to a parent?
That's a great teaching moment. You can think of the child's brain, specifically the RAS, as a radio trying to pick up a signal in a storm. Everything is just static and distracting. The stimulants, paradoxically, increase the stimulation of the RAS.
So it heightens their alertness.
Exactly. But it doesn't make the child more hyperactive. Instead, it allows the brain to become more selective. It helps filter out the static so the child can focus on the relevant signal.
It improves selective response.
Okay.
Now, most of these are controlled substances because of the high risk for dependence, but we do have non-controlled options now.
We do, and that's helpful. Atomoxetine, a selective norepinephrine reuptake inhibitor, is a popular non-controlled option. It avoids those systemic stimulatory effects. Guanfacine is another one, an alpha-adrenergic stimulator, and we also have to mention lisdexamfetamine, or Vyvanse. It has a black box warning that while it's approved for binge eating disorder, it is absolutely not approved for weight loss.
Got it. The adverse effects are pretty predictable: nervousness, insomnia, anorexia, weight loss. But there's one cardiovascular safety check here that is non-negotiable before therapy begins.
Yes. There have been documented cases of sudden cardiac death associated with these drugs, primarily in children with pre-existing undocumented cardiac defects.
So because of this,
A baseline ECG is required for every child before they start therapy. You have to screen for congenital heart problems.
let's focus on the unique role of the school nurse here. This is a very specific nursing focus.
The school nurse's role is so multifaceted, they often administer the long-acting preparations like Concerta or Metadate CD. This is crucial because it reduces stigma, prevents diversion, and cuts down on trips to the nurse's office.
But their biggest role is coordinating that periodic drug interruption, right? The drug holiday.
It is challenging, but it's essential. By periodically stopping the medication, the team can figure out two things. First, do the symptoms actually recur without the drug? This confirms its ongoing necessity. And second, has the child maybe matured developmentally past the need for the drug?
For general implementation, remember to administer the drug before 6 p.m. to prevent insomnia and dispense the least amount possible to minimize abuse risk.
So we've navigated the three pillars of psychotherapeutic care. We've got the dopamine and serotonin blocking antipsychotics with their spectrum of EPS. We've got the membrane stabilizing lithium, which demands an absolute dedication to monitoring that narrow therapeutic window. And the paradoxically calming CNS stimulants, which require that baseline ECG for cardiac safety.
And in every category we discussed, what really stands out is the profound role of individual differences. Patient demographics and treatment response. The source material notes that African Americans, for example, may respond more rapidly to antipsychotics, but critically, they also have a greater risk for adverse effects like tardive dyskinesia. They often need lower starting doses.
And what about with lithium?
They also display a higher red blood cell to plasma lithium ratio compared to Caucasians, which increases the potential for lithium toxicity even within those standard ranges. So if we know that these metabolic and response differences across various cultural and ethnic groups directly impact drug effectiveness and patient safety, what does this mean for the future of standardized care? The next frontier isn't just better drugs, it's personalized medicine. How essential is it that we fully integrate pharmacogenomics, studying how genes affect a person's response to drugs, into routine psychiatric care? That's a critical question for you, our learner, to consider as you continue your own deep dive